In the case review today, we're going to talk about vaginal myomectomy. So first, we're going to start out with what is a vaginal myomectomy, and it is a minimal invasive technique that preserves the uterus while removing polyps or fibroids in the uterine cavity. Another name for this would be hysteroscopic myomectomy. Anatomy involved. So for the layers, here we'll start with structure first. So for structure, we have the vagina, which that is the access route of the procedure, and then we have the cervix. So in this procedure, we're probably going to be retracting it, well, depending on where the fibroid is in this location. And then we have the uterus, which is a target organ, and then our fibroids. We're gonna then continue to the layers. So for layers, we're gonna talk about the vagina epithelium first, which is the innermost lining of the vagina. Then we have the submucosal connective tissue, which is beneath the mucosa, which is like under it, which contains the blood vessels and nerves. And then we have the outer layer of the vaginal wall, and then the uterine wall, which includes all the serosa, myometrium, and endometrium. Then we want to talk about the nerves. We have the pelvic splenic nerves, the inferior hypogastric plexus, and the pudendal nerve. For blood vessels, we have the vaginal arteries, the uterine artery and its branches, and the venous plexus. So for pathology and potential preoperative diagnosis, we'll talk about pathology first. So for pathology, we have the uterine fibroids are bend and smooth muscle tumors of the uterus. So it does state that these can cause abnormal uterine bleeding, pelvic pain, infertility, and other complications. So that leads us on to preoperative diagnosis, which would be like symptomatic submucosal or pedunculated fibroids prolapsing into the vaginal or lower uterine segments, and this is obviously confirmed by clinical examination and imaging. Then we go on to diagnostic tests that are performed. So for preoperatively to verify or rule out this diagnosis, we're first there's a couple things that may vary, but some things that are done would be a pelvic examination, a transvaginal ultrasound, an MRI pelvis, which it states that this is used in complex cases or mapping, and then CBCs, so like access to anemia due to excessive bleeding, and intraoperatively to guide the surgeon's decision making regardless of this diagnosis. He sees direct visualization and palpation during surgery. In some rare cases, intraoperative ultrasound is done. So then we want to talk about the types of anesthesia utilized for this procedure. General anesthesia is mostly common, but there's also regional anesthesia, which is like spinal or epidural, which can be in certain cases, but it's still stated on there. Then we want to talk about patient care monitoring equipment that is expected. So for basically most of the majority of cases, it would be ECG monitor. You would have most of these for any surgery anyway. So ECG monitor, pulse oximeter, a non-invasive blood pressure cuff, a capnography, which is if under general anesthesia only, a temperature probe, a Foley catheter. So the surgical positioning for this surgery will be a lithotomy position, and then some of the aids used would be stirrups, padding for legs, arm boards, safety straps, even more padding around the body just to get it to that perfect position. And it also, I think it varies between the surgeon also and how they want the patient positioned. Incision or access site. So there's no abdominal incision. Access is transvaginal, so the vaginal canal and cervix. So then we go on to skin prepping. So for skin prepping, we want to prep from the abdomen, so the umbilicus down to the mid-thigh, including the inner thigh, and making sure we're getting on those crevices and the perineum. We want to use, it's basically surgeon's preference, or sometimes they will stay on there what they want, but povidone, iodine, chlorhexidine solution. And then for draping, I think this is pretty simple, so it's not as complex. So first we want to go in with our 4 towels, square our incision, not our incision, but where we're going to be working, right? Next we would want to put leggings, under buttock drape, and then a fenestrated drape. Then we want to go into our instrument setup. So for obviously the first thing we're going to probably use is going to be a retractor, so speculum, Sims. Then we can use tenaculum, scissors, tissue forceps, obviously needle holders, sponge forceps, suction tip, dilators, uterine sound. So surgical equipment commonly used. So we could talk about hemostasis, so Bovie or any electrocautery, anything, fixation. We could use suture or maybe other agents, but probably suture. So then we want to talk about the sequential steps of the procedure. So we first want to do patient positioning and skin prepping, get them into lithotomy position and antiseptic solution when we're prepping this patient. Then we want to go in with our draping. We talked about our 4 towels, leggings, under buttocks drape, the fenestrated drape, and then we go into the vaginal access, so speculum insertion, which is usually what is used, but retracting incision, so vaginal mucosa incised with scalpel, and then they obviously do the vaginal wall retracted, right, with Sims or obviously any retractor. So then they are dissection to target, so blunt, sharp dissection, right? So they might go in with smets or something, and then their fingers to expose the myoma. Exposure, so to expose, we'll use a retractor for good visualization. Excision or repair myoma grafts with probably a tenaculum or anything else, depending on what the surgeon is using to grasp. Excised with scissors, then uterine wall repaired with suture. Hemostasis, Bovie, or other agents, or even like suture, irrigation, normal saline, or water, and we're probably using a bulb syringe. And then obviously we want to have a suction tip or something for that as well. We could also use the butt drape. A closure, vagina mucosa closed with Vicryl, and we would get to further on what type of Vicryl you would want to use or is preferred. Dressing, vaginal pad, sterilized gauze, and an external pad. For closure now, for suture, so uterine wall, absorbable suture, Vicryl 2.0, 3.0. Vaginal mucosa would be the same thing. Then we want to go in with our count routine: sponges, needles, instruments, right? Needles, we are hypos, Bovie tips, anything that's needed for this. Specimen care. So for on the field, you would place it in a sterile container, and off the field we want to get specimen, label the specimen, and then follow surgeon instructions. Wound classification, so this would be class 2, so clean contaminated due to the entry of the vagina. possible complications. So this could be bleeding, infection, uterine perforation, adhesion formation, damage to adjacent organs. Post-operative complications could be infection, hemorrhage, delayed healing, or just pain. And then I do have a video listed that really goes into detail on what it is, what happens to the body, and it even shows how the surgery is done, which is an amazing video. Really very informative. They even go in on what to do and what to cut and what to watch out for. I think it's a great video.